If you have anything to present, in the meanwhile, you can continue. I'll be just starting in a couple of minutes. Okay.
Okay, continue to share. Hello everyone, and I'm Dr. Hariharan Sivaraj, and this is the first official meeting after I got my diploma, and this is so special for me. I'm Hariharan Sivaraj. I'm the founder and director of the Team NAMMA Medicine, and welcome to Team NAMMA Medicine. Next slide, please. Okay. Okay. What is NAMMA Medicine means? NAMMA Medicine is a non-profit organization. It networking and bridging the gap between Indian foreign medical graduates and the world-class clinicians. Okay, we start NAMMA Medicine with a group of medical students and mentors who believe the meaningful guidance should be accessible to each and everyone. And our goal is to provide a supportive space where the students don't just prepare for the next exam, next test, but for the kind of doctor they want to become. Next slide. Next slide, please. You just keep it like this, okay? And as of now, we are 3,000 plus students have enrolled in our NAMMA Medicine, and we have around 100 plus mentors all around the world, from UK, USA, India, and Australia, and everywhere, from AIMS to JIPMER, from Madras Medical College, and everywhere. And we have hosted around 60 plus educational webinars. The webinar, what you are going to have like this. And we have done around 25 plus community projects, and we will discuss it. Next. Our core mission is to educate, transform, and empower. And next. Next slide. And we have around 2 to 3 units in NAMMA Medicine. We have an academic event and guided mentorship for those who are planning for an Indian or any foreign examinations like usmle, ukmla, and EMC or anything like that, and about the research. And we have the mannequins also, and we will provide a hands-on training on CPR and intubation and essential clinical skills, what you want to know. Next. And professional development unit is the unit. It is one of the excellent unit in NAMMA Medicine, because this unit will teach you regarding the communication skills, interpersonal skills, how you should present yourself as a doctor, and the accountability and the humanism and interpersonal skills like that. Mental health unit is, as a doctor's primary priority must be self-sanity, and med school scholastic syllabus takes a toll. And we provide professional listening ears and leaning shoulders to ensure the future doctors have the mental stability and require to safely deal with the human lives. And next. And this is our community programs, and we go to the community and we do some health programs and awareness programs. I will discuss in further slides. Next slide. And Project Valalar, we have 3 projects as of now. Project Valalar, that is we have fed around 1,000 plus people in India and Philippines. And the core theme is preventing the illness by restoring basic dignity and nourishment. And the project Valluvan is like health programs we will conduct in the community, and it's like a diabetes hypertension program, and we free sanitary napkins. We have provided free sanitary napkins, and we have done pediatric cancer toy drives at SPMC hospitals for the kids, for pediatric population. And Karpom is like something like an awareness program for the public. We teach and we make awareness what that is considered as a taboo, like menstruation and HPV vaccination awareness and everything. And next slide. And this is some of our camps and everything. Next slide. And this is empowering the next generation, catching illness before it takes a root. Our volunteers step into the schools and to lead open conversations on deeply stigmatized topics like menstrual hygiene, PCOS awareness, menstrual health, building, and general like that and all. Next. And we have done last year we have done HPV vaccination program. We have vaccinated 2 doses of vaccines for 65 individuals, and we educated them regarding the HPV cancer awareness also. And we have done pap smear awareness also. That was being presented by 17 plus NAMMA medicine volunteers and 5 doctors, including a leading gynecologist. Next. And every session that we conduct in NAMMA medicine and every message we share and every connection we build is rooted in a purpose, community, and compassion. Next. And as usual, I have said before, we have a lot of mentors from the lot of the prestigious university. Next. Okay. Next. Okay. You can enroll us. Next. Okay. Sorry for the slide, guys. Sorry for the slides. And our today's on behalf of NAMMA Medicine, warmly welcome you all to the Drips, Drops, and Disorders episode 1. At the beginning of a new academic series dedicated to practical and clinically relevant topics in fluid electrolytes and acid-base disorders. Today's session is Think Before You Drip, Mastering IV Fluid. It focuses on one of the most frequent and crucial decisions in the medicine, prescribing IV fluids. Every fluid order is a clinical intervention that requires careful assessment of the patient and with sound judgment and an understanding of deep physiology. We are honored to have Dr. Praveenkumar Natarajan, sir, MD General Medicine from MMC and DNB General Medicine and DM Nephrology from the MMC. And I'm proud to say he secured All India rank 1 in NEET SS and ESE Nephrology and consultant nephrologist at Tamil Nadu Government Multi Super Speciality Hospital. And our sir is widely respected for expertise in nephrology, fluids, and electrolyte management and evidence-based clinical practice. We are grateful to have him for joining us today and sharing his valuable insights. As the first episode of the series, we are excited to announce that further sessions will explore common and challenging electrolyte disorders in depth. Our next episode will focus on hyponatremia, covering its evaluation, classification, diagnostic approach, and the management, along with the discussions on other important electrolyte disturbances in the episodes is to come. We thank all the participants for being a part of the educational journey and look forward to continuous support. Without further delay, I invite Dr. Praveenkumar sir to begin today's session. Thank you, sir. The stage is yours.
Thank you, Ariharan. Thanks for the kind introduction. So, if everything is right, I think we can start with the presentation. Okay, is my slide visible?
Yes, sir.
Okay. So just don't get carried away by the looks of the so many slides which we have today to share. It's like almost around 50 slides. But then, yeah, most of them are images. I think there is no much theory to discuss. And I have like catered this discussion mostly to post MBBS people and probably MD postgraduates, not a nephrology level discussion, possibly, considering the audience we have. So just a disclaimer, I'll not be discussing a lot about all the trials, all the big evidences behind each recommendation. So that is like well beyond the scope of this lecture. We'll just go ahead with the facts, which should be remembered by anyone who's intending to give IV fluid therapy to anyone. Okay. So yes, Ariaran called me like some days back regarding the series which we have been long planning about fluids and electrolytes. So I just wanted to start with some basics about IV fluids because IV fluid therapy is very common. It's like extremely common throughout the world that it is not even considered as an invasive therapy because according to me, anything which goes inside our vein directly, inside our bloodstream directly is an invasive therapy because we think that doing an invasive procedure or opening the body and doing a surgery is the invasive procedure, but then IV fluid therapy is invasive because just think about how our body defends ourselves against all the pathogens. So for some pathogen to enter the bloodstream, it takes a lot of things. Okay, we have so much barriers to enter into our own bloodstream. Whereas IV fluid therapy is one where we just poke the vein and put whatever inside. Okay, so it just directly gains access to the bloodstream. And anything which gains access to the bloodstream, you all know it can get seeded anywhere in the body. Okay, so IV fluid therapy is one such invasive treatment, according to me, which is like very commonly done, that it is no longer seen as an invasive therapy at all. Okay, so that's why I just wanted to go have a brushing of what our IV fluids are and how we should go about with that. Okay, so is my slideshow on?
Yes, sir.
Is it in the slideshow view?
No, sir. No, sir.
It's in the slideshow view, right?
No, no, no. Yes,
No,
sir. Yes, sir. It is. It is.
It is. Okay. Okay. Fine. Okay. So yes, we have a lot of learning objectives, and one learning objective will be I'll be putting forth some scenarios for you at the beginning itself. Okay. So if everyone is able to answer these scenarios at the end of the lecture, then I am done with my course. So I think someone is like starting to scribble. It is not me. So someone is angry on me. Please don't do this in the class. Okay. So case one, we have a patient who's having septic shock. BP is 80/50 with tachycardia, and the patient has increased lactate level. So when you are like given with such a patient, which is very common with every MD postgraduate, like we get tens and twenties cases per admission day. So what fluid will you choose? Second case is someone with diabetic ketoacidosis. What fluid will you choose? And the last one is my own specialty. You're having a patient with chronic kidney disease on pulmonary edema. He is having elevated JVP, BP is high, creatinine is high. Should fluids be given at all? So these are the three scenarios which we should go and just discuss about at the end. Okay. So the key message here is IV fluids are drugs. Remember that they are not just like water, glucose, very commonly fondly called as glucose. Okay, so IV fluids are not just mere fluids, they are actually drugs. So wrong fluid at the wrong time can cause like very bad outcomes, detrimental outcomes. I have seen a lot of, mishaps happen right in front of my eyes. And right fluid can save lives. That is the most important positive thing which we should remember from this. Okay. Hariharan, is it possible to stop someone from annotating the, uh, you know, slides?
sure will do, sir. Sorry, sir.
Okay. Because this will stay till the end. So if you can just remove the annotations, it will be like quite good. If you go to the pointer options at the end, there will be something called erase all in con slides. I think you can do that. Since I'm not the host, I will not be able to do that.
I will do, sir. I'm really sorry, sir.
Okay, done? Okay, great. Okay. So every fluid therapy class starts with this slide, which is like very important. You read it 100 times and sometimes you will still forget it. Okay. So if you take a look at watermelon has 99% of water. Still, it becomes huge and it's a solid mass right in front of us, but it is 99% of water. Okay. Just like that, a human body, even though we appear like quite a solid substance, an adult male is about 60% of water. So just think about 100 kg male will have 60 kg of water. So that's how our body is designed. And if it's a female, it's going to be 50%. And look at the neonates, almost 75 to 80% is going to be made of water. Okay, so such is the composition of body water which we have from birth. And if you have a division of where this water goes into, around two-thirds of the total body water is going to be intracellular fluid, okay, which is inside the cell, and one-third is going to be extracellular fluid, which is outside the cell. So the fluid which is outside the cell can be divided as either interstitial fluid or plasma. Okay, this interstitial fluid is going to be three-fourths of the extracellular fluid, and one-fourth is going to be plasma. Okay, so these are all the numbers which you can have. Just a moment. Is my slide visible again?
Yes, sir.
Okay, but then I am not able to see that. Just give me a moment. Okay. So yes. So 3.5 liters is the usual plasma volume, which is like 1/4 of the entire extracellular fluid. Okay. Just take a screenshot of this. This is going to be extremely important whenever you decide a fluid therapy. Okay. Yes. I'm still having some technical difficulties. Okay. Right. Okay. Is it visible now, Ari?
Yes, sir. Visible,
Yes.
sir.
Okay. Sorry. So coming to the electrolyte composition of the intracellular and extracellular fluid, remember one important thing, extracellular fluid, the major content is going to be sodium. Okay. We all know the normal sodium content in the extracellular fluid in our plasma is going to be 135 to 145 milliequivalents per liter. So that is the major, positively charged ion, which is a cation. And the negatively charged ion is going to be chloride. So sodium and chloride are the major electrolytes which are present in the extracellular fluid. When you go into the intracellular fluid, it is going to be potassium, which is the major positively charged ion, and phosphate, which is going to be the major negatively charged ion. Okay. This is again very important because whenever you give any fluid which is rich in sodium, this is going to stay in the extracellular fluid because sodium is going to be the electrolyte of the extracellular fluid. So if you give a fluid which has a lot of sodium, it is going to stay in the extracellular fluid. This is the take home message once again. Okay. So sodium determines the extracellular fluid volume. Now coming to some other key concepts. Okay, osmolarity, and tonicity. Okay, so nothing again. It's not more of a physics class. We just want to know a few things because we use this milliosmoles per liter and stuff in our day-to-day life. So we should know what it is. So osmolality means the amount of a solid which is suspended or dissolved in a liquid. Okay, for example, if you say 1 liter of water is there. Okay, in 1 liter of water, how much solute is there? That is called osmolarity. Okay, so osmolarity, RITY, that means it is in liter. Okay, if you take 1 liter of water, like say 2 grams of salt is in that, then we call that as osmolarity. Okay, but osmolality, LITY, means it is the same amount of salt which is dissolved in 1 kg of water. Okay, it's 1 kg of water. So one is about weight, another is about volume. So can anyone just let me know why do we need to have this difference? Because 1 liter of water is going to be 1 kg, right? That's what is normally being assumed. So why do we need to have this? Any idea? I have kept my comment boxes open so that I can have a discussion just like that. Yes, someone says temperature. Exactly. Because at room temperature, 1 liter of water is going to be 1 kg. But if you heat the water to a higher temperature, its volume expands. Okay. Its weight will remain constant. Okay. Its weight will remain constant, but then its volume expands. So instead of 1 liter, it can be 1.05 liters or something like that. Okay. So when the volume expands, then the amount of solute will be like a sparse. Relatively, it is going to be sparse. So in a boiled fluid, the osmolarity is going to be less. Okay, because the solutes are like sparsely distributed. So that's the reason why we usually prefer osmolality, the kg thing. That's why we usually okay, you take a cell. Okay, this cell has some concentration of solute or something. Okay, now you take another liquid. Okay, if this liquid has lesser salt, okay, lesser solutes, okay, when compared to this cell, then this fluid is called hypotonic. Okay, it is less concentrated than the cell. Okay, if the fluid has a higher concentration of solutes, then we call it as hypertonic. Okay, so what is the meaning of this and what is the clinical implication of this is, if at all you have a hypertonic fluid, okay, if at all you have a hypertonic fluid which is which is outside a cell, it will draw all the water from the cell and the cell will become dehydrated. Okay, if you have a hypotonic fluid, if you have a hypotonic fluid, that is free water doesn't have any solute at all. So if you keep a cell inside a free water, this free water will enter the cell because cell is more concentrated, so that will absorb a lot of water and the cell will swell. Okay, so this is what happens when you give a hypertonic fluid or a hypotonic fluid. So hypertonic fluid makes the cell dehydrated, whereas hypotonic fluid makes the cell swell. So this is again one concept which we should remember. Okay. Now coming to the solutes per se, I told about the amount of solute which is dissolved in a liquid and all these things, but not all the solutes are going to be the same. Okay, the solutes can either be an effective osmol or an ineffective osmol. So what do you mean by effective and ineffective osmol is, consider sodium. I said sodium is the major component of the extracellular fluid, right? So it's in the extracellular fluid. So if you give sodium through intravenous route, the sodium gets distributed only in the extracellular fluid. It doesn't go into the intracellular fluid at all. Okay. So this sodium will be accumulated in the extracellular fluid. So that extracellular fluid, the osmolality of extracellular fluid will increase. Okay. So this contributes to the osmolality of the extracellular fluid. So something which stays in a particular compartment and increases its tonicity is called an effective osmol. So an example is going to be sodium or mannitol, which stays in the extracellular fluid and then it draws water from the intracellular fluid. Okay. Now consider some other solute like urea. Okay. So urea, if you give 100 milligrams of urea, or if you give 1 gram of urea, if you take 1 gram of urea either as IV or oral, this 1 gram of urea is going to be distributed throughout your body. That means it will go into the intracellular fluid, extracellular fluid, inside the extracellular fluid also, both interstitium and plasma. So everywhere it will get equally distributed. So how much ever urea you will give the patient, that will not be staying in one particular compartment. So only when it stays in one particular compartment, it is going to be a effective osmol. If it doesn't stay, then it doesn't cause water movement at all, right? Because it is equally distributed among all the compartments. So there is no hypotonicity or hypertonicity. So there is no movement of water at all. So these are called ineffective osmols. Okay. Again, this is very important because I'll give you one particular example. So consider this particular image. Okay. So we have the intracellular fluid, which is like very huge. And we have the extracellular fluid. In that extracellular fluid, we have plasma, which is a small bit, and we have an interstitium. Okay. And we all know the main driver of human basal metabolic rate is going to be this sodium potassium ATPase pump. So that's the reason why sodium is in the extracellular fluid and potassium is in the intracellular fluid, because this pump, it pushes all the sodium into the extracellular fluid. Okay. And it pushes all the potassium into the intracellular fluid. Okay. So that only maintains the sodium and potassium balance between all these fluids. Okay. Now let us consider we give an ineffective osmol. Okay. For example, urea. I said ineffective osmol is an urea. Okay. So we give urea through IV route. If you give anything through IV route, it goes into the plasma, right? It directly goes into the plasma. So initially it will be in the plasma. But as time progresses, you can see that the urea gets distributed equally throughout all the compartments. Okay. Now the concentration of urea in all the compartments is going to be the same. And whenever there is similar concentration in all the compartments, there is no movement of water. So addition of how much ever urea is not going to cause any change in your water movement. So we call urea as an ineffective osmol. Now consider some other thing, sodium. For example, you are giving sodium chloride or 3% saline, okay, which has a lot of sodium. Okay. So again, you are giving it in the plasma compartment. Okay. Where the sodium gets accumulated, we all know that where the sodium gets accumulated, it gets accumulated only in the extracellular fluid. So as time moves on, the sodium from the plasma will go into the interstitial space also, but it will not be going into the intracellular fluid. It stays only in the extracellular fluid. Okay. So now we have given more sodium here. Because of this compartment is going to have a higher concentration. Whenever this has a higher concentration, it will pull water from the intracellular fluid. So water will come from the intracellular fluid into the extracellular fluid. So this now acts as a effective osmol. Okay. Effective osmol for the extracellular fluid. So this is about the sodium containing fluids. Now we go to the third part, which is colloids. For example, we give 5% or 25% human albumin. Okay. See, albumin is a plasma protein. So all the plasma proteins are confined to the plasma, right? So if we give plasma protein infusion directly into the plasma, even if there is a lot of time given to that, it will not be distributed to any other compartment. It will still stay in the plasma only. It will keep on moving in the plasma only. Okay. So what it effectively does is it pulls water from the interstitium, it pulls water from the intracellular fluid, from everywhere it is going to pull water, and it will expand your plasma volume. So we call these colloids as plasma expanders because they expand the plasma volume. Okay. So till this, are you clear? If you are clear, just give me a thumbs up so that I can just proceed with it. Done? Okay, great. Fine. So we'll now go to the next part. Hariharan, is it okay if I just quit and come back once again? Just a moment.
Sure, sir. Sure, sir.
There's some issue. I'll just be back right away.
Sure, sir. First, yes, we got some idea about what is osmolarity, osmolarity, and everything. Have we got it? Hypotonic, hypertonic, isotonic. Sir, you're muted, sir. Oh my God. Sir, Yara mute me, sir. Sorry, sir. I'm not the host.
Okay, not a problem. I was not allowed to unmute myself. It's okay. We'll just continue. Okay. Yes. So again, this is once again a small slide which depicts what exactly is happening. Yeah. So just have a look at this. Body fluid, we have a lot of compartments. And if we give 5% dextrose, instead of that, you can just consider it as a free water. I'll tell you why 5% dextrose is just considered as a free water. That is just plain water. Because if you go back to the previous slides, okay, I have given one particular thing, okay, about glucose. Glucose is still considered an effective osmoles, but only when it is in the extracellular fluid. But is it usually the same? Means no, because whenever we give glucose into the IV space, okay, inside the plasma, this glucose is going to be taken up by all the cells and it will be metabolized. So that if you are giving some 50 grams of glucose in 1 liter of water, this 50 grams of glucose is going to be taken up by all the cells and it is going to be metabolized. So finally, what is left is only the 1 liter of water. Okay, so this water is going to be just plain water without any effective osmoles at all. Okay, so that's the reason why we usually consider glucose containing fluid as free water. Okay, it is just like giving plain water to the patient. So that's the reason why if you give 5% dextrose, the glucose is going to be taken up by all the cells. It will be metabolized. So only plain water will be there. This plain water is going to move through all the compartments and it fills all the compartments. Okay. Now the isotonic saline, which is sodium chloride, I said sodium is restricted only to the extracellular fluid. So it is the interstitial fluid and intravascular fluid. Okay, it stays in the extracellular fluid only. If you give colloids or if you give blood products, that is going to stay only in the plasma volume because they contain a lot of protein. So it stays in the plasma itself and it expands the plasma. Okay, this is again one just slide to show you that. This is again with numbers you will be better able to understand. So now consider D5 water. D5 water is 5% dextrose. I said 5% dextrose is just like giving a free water, right? It is just like giving free water. So if you give 1 liter of dextrose to a patient, okay, this fills equally in all the compartments. We know 2/3 of the total body water is going to be intracellular fluid, right? So 2/3 of 1 liter is going to be around 666 or 667 ml. Okay, so 667 ml is going to be in the intracellular fluid, and the remaining 333 is going to be in the extracellular fluid. And in the 333, 3/4 is going to be in the interstitial fluid, and 1/4 is going to be in the intravascular space. That is, only 83 ml of water is going to be in the intravascular space, and 250 ml is going to be in the interstitial space. Do you understand this? Because I'm going to ask you one question and I would like you guys to answer that. Now, we saw the sepsis patient as the first case, right? BP is 80/50. Okay. So when a patient is having 80/50 BP, they usually say go and give normal saline or ringer lactate or something like that. Okay. Why can't we give 5D to this patient? We can give 1 liter 5D to that patient, right? What is the problem with that? Why can't we give 5D? Yes. Someone says it is poor plasma expansion. Exactly. Because to increase BP, what you should do is you should increase the plasma volume. But if you give 1 liter of this dextrose, most of it is going to be going into the intracellular space. It is not going into the extracellular fluid at all. Even if it goes into the extracellular fluid, 250 ml is going to be in the interstitial space. Okay, only 80 ml is going to be in the intravascular volume. Think you give 1 liter of fluid to the patient, but then only 80 ml goes into the plasma. That is not at all going to increase the plasma volume. It's just like negligible amount. Okay, that's the reason why we usually don't give 5% dextrose in any shock patient. Okay, and think about this: 660 ml is going into the intracellular space, so it is going to go and cause the cellular swelling. If at all you are giving this fluid to someone who's already having cerebral edema, okay, for example, traumatic brain injury, a patient is there, you are giving 5% dextrose for some reason, then this is going to go directly into the brain because brain has a lot of cells. It goes into the intracellular fluid and then it is going to cause brain cell swelling. When it causes brain cell swelling, you have a uh, brain which is already swollen, which is going to swell more and cause cerebral edema, and the patient will die. So basically, this is a medical negligence. So we should never give 5% dextrose in a state where there is already some swelling somewhere in the body, which can cause some serious consequences. Now consider NS. Okay. So I said NS is normal saline, which has only sodium. If you give a fluid which contains sodium, I said it is going to stay in the extracellular fluid. It is not going to go into the intracellular fluid. So it stays in the extracellular fluid. So if you give 1 liter of sodium chloride, 1 liter of normal saline, it is going to stay in the extracellular fluid. In the extracellular fluid, it will distribute equally. Okay, it will distribute equally in the extracellular fluid. So extracellular fluid has 3/4 of interstitial fluid. So 750 ml is going to go into the interstitial space and 250 ml is going to stay in the intravascular space. So if you give 1 liter of fluid, you are expanding the plasma volume by 250 ml. So this is going to be much better for plasma expansion. So any patient who is having hypotension, it is better to go ahead with sodium chloride, or even have a look at ringer lactate. Ringer lactate is also something which is like more physiological, which has almost similar composition of our plasma. Okay, it has sodium, it has potassium, it has chloride. Okay, which is almost similar to plasma. So this is going to be staying in the extracellular fluid only. It is not going to go into the intracellular space. So that is also similar to normal saline. So normal saline and ringer lactate, they do have similar properties. Okay, we'll just discuss why they both differ and why normal saline is being replaced with ringer lactate these days. Okay, we'll be discussing about that as well. Okay. Now continue. Now consider albumin. I said albumin is a plasma protein. If you give it into the intravascular space, it stays in the intravascular space. So if you give 1 liter of albumin to a patient, what will happen? If you give 1 liter of 20% albumin to a patient, what will happen? Next day we'll be sitting in the jail because we can't give 1 liter of 20% albumin to any patient. Okay. The amount which we can give is like give 100 ml of 20% albumin and then see how it is going to be. What is the reason? What is the reason? 20% albumin. 20% albumin, now what does it sound like? Percent means per 100 ml, right? So 20% albumin means in 100 ml of fluid, there will be 20 grams of albumin. 100 ml of this fluid, 20 grams of albumin is going to be there. But what is the plasma concentration of albumin? It is 5 grams per deciliter, right? It is just 5 grams per deciliter, but we are giving like 5 times higher concentration of albumin. So this is going to expand your plasma volume by 5 times, basically. If you give 100 ml, if you just give 100 ml of 20% or 25% albumin, that is going to expand your plasma volume by 5 times. 5 times mean not the entire plasma volume. You are giving 100 ml of fluid, that will become 500 ml of fluid in the plasma. Okay, because it will reabsorb a lot of water from the interstitial space, from the intracellular fluid. It will take in a lot of water because you are giving so much oncotic pressure. Okay, through this albumin, you are giving a lot of oncotic pressure through this albumin, so it will reabsorb a lot of water. Okay, so that's the reason why how much ever albumin you give, it stays in the intravascular space. So we call albumin as plasma expander. That's all. So again, this slide deserves to be taken as a screenshot. Even this is very useful for me. You can just take a screenshot of it so that we can move. Okay. So the next slide. Again, I'm just having a lot of problem with this thing. Let me just see. Just give me a moment. Okay. So it's visible clear now? Right. Okay. Now we'll go into the classification of IV fluids. Okay. So classification of IV fluids, just two types. One is crystalloids and the other one is colloids. And which is the most commonly used? Crystalloids or colloids? Which is very commonly used. Crystalloids are. I want the text box to be very active so that I can get a feedback on like whether you're able to understand or not. Yeah. Yeah, so crystalloids, because crystalloids includes the NSRL, which are the most commonly used IV fluids, and colloids, albumin, you have hydroxyethyl starch, dextran, and other gelatins also there. We are not going to discuss too much in details about colloids because it is less used, and it again is like a different kind of discussion. We'll just touch upon that, but we'll restrict ourselves most to the crystalloids because that is like very important for all of us. Okay, so crystalloids are something which expand both intravascular and interstitial space, which means it expands the extracellular fluid. Okay, all the crystalloids. But colloids, it just stays intravascular. Okay, just keep repeating these terms inside because intracellular fluid, extracellular fluid has interstitial space and it has plasma. Okay, so you have to keep on repeating this, else you will get confused. So crystalloids, it stays in that full extracellular fluid volume. Colloids, it just restricts itself to the plasma. Okay, this is the take home message. Okay, now we go to a classification based on tonicity. I think I have told you about this. So something which is similar in osmolality to plasma is going to be isotonic. Something which is which is having less osmolality is called hypotonic, and more osmolality is called hypertonic. So the most common hypertonic fluid which we know of is going to be 3% saline. This is commonly used 3% saline, hypertonic saline. That's what we say. And the most commonly used isotonic fluid so far has been normal saline, but from here on it is going to be ringer lactate. Okay, so far it has always been NS for all the things, but now there is a change in the entire thought process. Everyone is prescribing RL, that is balanced solutions for most of the indications. We'll just discuss about that. And commonly used hypotonic fluid is going to be dextrose 5 water, that is 5% dextrose. That is going to be the hypotonic fluid. Okay. Now we'll start with few salient features of each of these fluids. One is normal saline, which is like 0.9% of sodium chloride. Okay, just see what is the composition of it. So it has just sodium and chloride, nothing else. It is sodium, chloride, and water, nothing else. So the concentration is going to be 154 milliequivalents per liter of sodium and 154 milliequivalents per liter of chloride. Okay, so can you tell me whether it is the same as plasma or it is higher than plasma? Whether it is same or higher. Yeah, it is higher than plasma, right? It is not exactly the same as plasma. It is a little bit on the higher side than the plasma, but still we do call these fluids as isotonic fluids. Okay. But remember, it is a little bit on the higher side. Okay. So what is the advantage is it is very cheap, it is widely available, it is the most commonly used fluid everywhere so far. Okay. And what is the main role of this? What is the main role of this is it is going to expand the extracellular fluid. I said sodium, Whenever sodium is there, it is going to expand the extracellular fluid. That's all. But what is the problem with these? That again is very important. What is the problem with this? So just look at chloride. Can anyone tell me what is the actual chloride level in the body? Sodium, we all know, 135 to 145. What is the chloride level, normal chloride level? Is it the same as sodium or is it different? Yeah, someone says it is 96 to 105. Yeah, right. So less than 106. Okay. But just look at the chloride concentration here. Okay. So chloride concentration here is 154, right? Which is like extremely high. So if you keep on giving so much chloride into the body, what happens is it will cause hyperchloremia. Okay, it will cause hyperchloremia. Hyperchloremia is increase in chloride. This chloride is going to be a negative ion. Okay, so whenever you are pumping body with a negative ion, what happens is the negative ion increases. Okay, but then some other negative ion should decrease to compensate for the electron neutrality. So which negative ion reduces is bicarbonate. So bicarbonate is the next common negative ion which is in the body. So this bicarbonate level is going to get reduced. What do we call it when bicarbonate level reduces in the body? What happens? Yeah, we call it as acidosis. What acidosis? When bicarbonate reduces, we call it as metabolic acidosis. That's all. So if you keep on pumping sodium chloride to anyone for any reason, you are going to put that patient in metabolic acidosis. Very simple. Okay. That's the reason why. Just think about DKA management. Diabetic ketoacidosis, you all would have known. Okay. They say start your resuscitation with normal saline because any patient with DKA is going to have dehydration. So the treatment of choice for dehydration is going to be normal saline. So you give normal saline till the dehydration corrects. But once the dehydration corrects, they ask you to shift either to half normal saline, which contains less chloride. Okay. They ask you to convert it into half normal saline or Ringer's lactate. Okay. So that you don't put the patient into more chloride overload. Because if you give chloride overload, already the patient is in diabetic ketoacidosis. Now you are increasing that acidosis by giving sodium chloride. Okay. So that's the reason why we don't give sodium chloride as the only replacement fluid in DKA. Okay. And can anyone tell me why there is potential AKI risk? Okay, they say, right, whenever there is a low BP, you give sodium chloride, like NS, we give NS and increase the BP. Only when the BP is increased, the acute kidney injury will not happen. But then if you continuously give sodium chloride, you are putting the patient at higher risk of acute kidney injury. Can anyone tell the reason behind that? There is quite an interesting mechanism. And you have a clue also. It is renal vasoconstriction. Why? Why do you have renal vasoconstriction? Because if you give a sodium chloride, your plasma volume is going to increase. When it increases, the blood flow is going to be good only. Why should it undergo vasoconstriction? Someone says RAS. So have you heard of something called tubuloglomerular feedback? Tubuloglomerular feedback. What is that? Tubuloglomerular feedback. Yo, someone says macula densa, juxtaglomerular apparatus, right? Okay, so what exactly happens is you are giving a lot of sodium and chloride. The sodium and chloride is going to be filtered in the glomerulus, and the sodium and chloride is going to go into the proximal tubule, then it goes into the loop of Henle, and it goes into the ascending limb of loop of Henle. So in the ascending limb of loop of Henle, you have something called macula densa. This macula densa senses sodium chloride. Among sodium and chloride, it is very sensitive to chloride. Okay, here by giving normal saline, you are actually increasing the body's chloride. So this macula densa senses a lot of chloride. Once it senses a lot of chloride, it will think that so much blood is coming into the kidney. That is why I am filtering a lot of chloride. Now what I should do is to cause renal vasoconstriction so that the filtration reduces. Okay, so this is a mechanism by which the kidney is actually protected from high blood pressure, okay, or high blood flow. So here you are giving a lot of chloride, so the kidney will think that it is filtering a lot. So it will try to reduce the filtration by causing renal vasoconstriction. So if we keep on giving, this can result in potential acute kidney injury. So these are all the problems with normal saline. Okay, it can cause metabolic acidosis, it can cause renal injury as well. Okay, fine. So the only reason which we commonly give is any patient who is having hypochloremia and low BP. Okay, even now, even though the recommendations have changed to give Ringer's lactate as a fluid of choice for shock, we still do give normal saline. All of you who is attending it will know that whenever you are going into the emergency department, they'll be like, BP is low, give normal saline. Normal saline is the fluid of choice. That's what we used to think. But then now it is being changed slowly. Okay. So these are the uses of normal saline. Then coming to Ringer's lactate. Okay, just have a look at this Ringer's lactate. Okay, it has sodium which is 130, which is almost okay with the normal, serum sodium. Chloride is 109, again much better than your sodium normal saline. Okay, normal saline it was 154. Here it is 109. It also has potassium which is 4. Okay, potassium which is 4 is again good because it is the same as your serum potassium. Serum potassium is going to be 3.5 to 5.5. That is the normal range. So here it is going to be 4. And another important thing is, as the name indicates, Ringer's lactate. We call it as lactated Ringer's solution. So it has a lot of lactate. Okay, lactate means lactic acid. Okay, this lactic acid, if you give into a patient, this lactic acid will be metabolized into bicarbonate by the liver. Okay, so how much ever lactate you give, 28 milliequivalents of lactate if you give, that is going to be metabolized into 28 milliequivalents of bicarbonate inside the body. So basically, this is like an alkalinizing solution. Okay, this is like an alkalinizing solution. So very commonly given for acidotic states. Okay, someone who is having acidosis. So for example, if a patient is having diarrhea, in diarrhea, they lose a lot of bicarbonate. Okay. At that moment, you can give Ringer's lactate to that patient because this lactate is going to be metabolized into bicarbonate, and this bicarbonate is going to correct the acid-base disorder. Okay. So this is the composition of Ringer's lactate. So advantages, as I said, it closely resembles plasma and it causes less hyperchloremic metabolic acidosis because the chloride level is going to be almost similar to the plasma. So it causes less acidosis and it has lactate, okay, which is metabolized to bicarbonate. However, be very careful. This is not at all to be given for any patient who is having severe liver dysfunction or lactic acidosis. The problem is this lactate is metabolized into bicarbonate by the liver. So if at all a patient is already having liver failure, if you give this lactate will not be converted into bicarbonate. This lactate will remain as lactate and that will worsen lactic acidosis. Okay. So that's the reason why we don't give RL for any patient who's having liver dysfunction. Okay. So any queries with this? So commonly it is used for fluid resuscitation, perioperative fluid therapy, maintenance fluid therapy, replacement of losses. Just look at this is the most common indications for which we usually give IV fluids, right? Resuscitation, maintenance, replacement, and perioperative fluid management. So almost everywhere RL is being currently considered. Okay. So that is little info about Ringer's lactate. Now to the less used substances like plasma light. So again, this plasma light is still better because it is very close to our plasma. Just look at the sodium. It is exactly 140. Chloride is going to be 98, perfect. Potassium is going to be 5. It also has magnesium and it has buffers also, which is acetate. Okay. Acetate again gets converted into bicarbonate. Acetate or lactate or citrate, if anything is there, it is going to get converted into bicarbonate. So this acetate is also going to be converted into bicarbonate. So it has almost everything. It's like a perfect package. Okay. The problem is it is a little bit costlier. That's all. That's the problem. So what is the advantage? You have electrolyte composition, which is almost close to the plasma and it has low chloride content. So acidotic risk is very high. It has a balanced pH. Just look at the pH. pH is going to be 7.4. Okay, it is going to be physiological pH. That is again very important. It is equivalent to the plasma pH. And this can be used again in all the settings which can be where RL can be used. It is almost similar. Okay, so fluid resuscitation, perioperative fluid therapy, maintenance fluid therapy, and GA loss. Everywhere it can be used. So what are the caution is, again, these are all like the generic cautions which we say we use in caution with renal impairment or liver dysfunction. Okay, this renal impairment is obviously whenever the patient is having low urine output, you can't give IV fluids. So it is like generic contraindication, no specific contraindications for this. So we can just like that brush it off. Okay, but again, due to cost issues, it is not being very commonly used in all the places. Okay. Now this slide, it's like a very busy slide. Okay, I'm not going to ask you guys to look at the top 2/4 and the top 2/3 intracellular fluid மாதிரி டாப்ல இருக்க 2/3 விட்டுருங்க, கீழே எக்ஸ்ட்ரா செல்லுலர் fluid மாதிரி 1/3 இருக்கிறத மட்டும் பார்த்தா போதும். Okay, so we have this memory tricks about this isolites. Okay, So isolate la isolate G, isolate M, isolate P அப்படின்னு இருக்கு. So very easy to remember. It is actually very difficult to remember what is exactly present in that, but then very easy to remember why they are used for. Okay. So isolate G. G means gastric loss. Remember, G is for gastric loss. So what is present in the gastric content, gastric secretion? What is the major component of gastric secretion? Any idea? Stomach is there for only one reason, right? What is that reason?
I don't know.
It has a lot of acid, that's all. Okay. Stomach produces acid. Okay. So whenever acid is lost, like vomiting, if a patient is having severe vomiting, okay, acid is lost. So you can give this isolate G because this isolate G contains a lot of ammonium, and this ammonium releases hydrogen. Hydrogen means acid. That's all. So it is more like giving an acid replacement. So whenever there is gastric loss, like vomiting, or if a patient is on nasogastric tube aspiration for a long time, then you replace the fluid loss with isolate G. That's all. So the major component is going to be ammonium, ammonium, ammonium. Okay. And next one is going to be isolate M. Okay. Isolate M, we can remember it is maximum potassium. Okay. Maximum potassium in any fluid which we can remember, because just look at the amount of potassium which is there. For 1 liter, it is going to be 35 milliequivalents of potassium, which is like a great extent. Okay, 35 milliequivalents of potassium. But I would like to give you a homework. Just go and check how much milliequivalents of potassium is present in one tender coconut water. Okay, 1 liter of tender coconut water, in fact, can have more than isolate M. Okay, amount of potassium. So it is like extremely potassium rich. Just go and check it out, because we can't just give 10, we can't just drink 10 tender coconut water per day thinking that it is very good. We will land up with hyperkalemia actually. Okay. So like that, isolate M, maximum potassium, it has 35 milliequivalents of potassium. That is going to be the most important electrolyte. So it is given for hypokalemia. Okay, can be given either as maintenance fluid for a patient who's on nil per oral, or patient with hypokalemia, you can give this. Okay. And the next one is isolate P. P is called, we can reach it as poor sodium. Okay. M is maximum potassium. P is for poor sodium. It has very less sodium. Okay, sodium is going to be 25 milliequivalents per liter only. Okay. So we can consider this as a free water. Okay. I said it free water, which is like very dilute fluid. So when do we give free water? Whenever there is free water deficit, we give free water. Free water deficit in the, what will be the electrolyte manifestation? Okay, what will be the electrolyte manifestation? If you are losing free water from the body, what will be the electrolyte manifestation? So body learned only plain water is lost. What will be the manifestation? What will your sodium levels be in the body? It is going to be hypernatremia, because your blood will become very thick and sodium level is going to be very high. Okay. So hypernatremia will be there. So for the treatment of hypernatremia or free water deficit, you can give this isolate T. That's all. So G is for gastric, rich in ammonium, given patients with gastric loss. M is like maximum potassium, give it for people with hypokalemia. P is poor sodium, give it for people with hypernatremia or free water deficit. That's all. If you remember this about isolate, it is like more than enough. Okay. If this is okay, put a thumbs up. We'll go to the next part. Yes. Okay. So now we'll go to the next part. So இவ்வளோ நேரம் பார்த்தது, we have sodium chloride, ringers lactate, isolates எல்லாமே பார்த்தோம். So sodium chloride is just like we call it as normal saline. And this isolate and ringer lactate, we call them as balanced crystalloids. We call them as balanced crystalloids because they have balanced amount of most of the electrolytes. So we call them as balanced crystalloids. Now this dextrose solution, as I said, what do we call dextrose as? We call it as free water. That's all. It's just free water, because all the dextrose will be utilized by the body once you give it inside the body, and then only water will be left. So when do we give it? So whenever a patient has hypernatremia. Okay. Hypernatremia means the patient is not having enough water in the body. That's why blood is very thick, so sodium is very high. So you have to replace water. So you can give 5% dextrose. Or think of a patient who has undergone a gastric surgery and put on nil per oral. Okay. So you need to give the patient, if the patient is not taking any fluid orally, any calories at all, you have to give some calories, right? So you can give 5% dextrose because it has a lot of Dextrose. Dextrose means it is glucose. That's all. Okay. So each gram of glucose is going to give what? How much calories you get? You are going to get 4 calories, right? 4 kilocalories. That's what we get. So we can give this dextrose solutions for patients who is on nil per oral. Okay. Now, this is what you should exactly remember. Don't give this 5% dextrose for someone who is on shock, thinking that you are doing good, because you are not at all doing good. If at all you are giving 1 liter of fluid, especially 5% dextrose, to someone who is having shock, nothing is going to stay in the blood vessel. Everything is going to go inside the cells and the interstitium. Nothing will stay in the plasma. Okay, so it is not at all indicated for patients on shock, and it is not at all indicated for resuscitation of anything. Okay, it is just to give calories to the patient or to treat free water deficit. That's all. Because once you become interns, you will be knowing whenever there is a hypernatremia patient, they'll be giving 5% dextrose infusion. Okay, they'll be giving 5%. The reason for that is going to be this is like a free water. You either ask the patient to drink a lot of water or you give 5% dextrose through intravenous route. But there is one catch in this. Can anyone tell me what is the problem with correcting hypernatremia using 5% dextrose? I said 5% dextrose is a free water. Now tell me, I am giving like 1 liter of 5% dextrose over 1 hour. What will happen? What will happen to the glucose level? Tell me now. What will happen to the glucose level in the body? 1 liter of 5% dextrose, I give in a short span of time, your blood glucose is going to be high. Okay. So whenever your blood glucose becomes high, what happens to the urine? You will have osmotic diuresis, right? So you are trying to correct you are trying to correct the free water deficit. But if you give 5% dextrose very fast, that is going to cause osmotic diuresis and the patient will lose more water. So that's why we shouldn't give 5% dextrose very fast. You should give it at a slower rate. Okay, again, there are rates for that. Okay, how much grams of dextrose can be given per hour. But then again, that is like too much for now. Just think that 5% dextrose should not be given very fast. It should be given slowly to correct the free water deficit. That's all. Fine. Now again, a summarizing slide. Okay. I think all your images are blocking my slides for myself. Okay. So yes, just look at normal saline. Chloride level is going to be very high. In Ringer's lactate, it is okayish, but still a little bit on the higher side than plasma. In plasma light, it is going to be almost equal to the plasma. So because it has a lot of chloride, the acidosis risk is high with normal saline. It is low with Ringer's lactate, and it is lowest with your plasma light. Potassium is not at all present in normal saline. It is 4 milliequivalents in Ringer lactate and 5 milliequivalents in plasma light. Buffer means like your bicarbonate or a bicarbonate equivalent. It is not present in sodium normal saline. In Ringer lactate, it is going to be your lactate. Okay, in plasma light, it is going to be acetate. Both these lactate and acetate are going to get converted into bicarbonate. So that will correct acidosis as well. So which is the best fluid from this? Plasma light is going to be the best fluid. Once again, the cost is a limiting factor for its routine use in all the hospitals. So this is like a summarizing slide for you. Okay. Now, this is the hot topic for now. Okay. Just see the bottom line alone. Normal saline is no longer the default fluid for everyone. Okay. Before this time, before like a few years ago, for everyone, it is going to be normal saline for everything. But now it is not normal saline. They always ask you to give balanced crystalloids. Balanced crystalloid means either Ringer's lactate or plasma light. Okay. Because lower chloride load, so lower risk of acidosis and better renal physiology. I said if you give more chloride, it can cause acute kidney injury. So because of all this, even in ICU, the preferred first line fluid has become your Ringer's lactate. Okay. So because it doesn't cause acidosis, it doesn't cause renal injury, we try to prefer Ringer's lactate, even for shock resuscitation. They say if a patient comes to you with septic shock, give 30 ml per liter of fluid bolus, and that bolus used to be normal saline all these days. But now it is going to be Ringer's lactate. Okay. So if at all you are asked any question, which is the fluid of choice for resuscitation, I don't know what you should write for the exam because I don't know what they have given in the key. But if you are given a patient and you have to treat, it is going to be Ringer's lactate. Because usually this NBE, NEET, they lag behind. Okay. Something happens yesterday, they'll be asking questions like from 5 years back. So I don't know how you should go about with that. But then for treating a patient, the latest evidence shows always balanced crystalloids are the better ones. Okay. So now, because of this, should we ignore sodium chloride at all? Should we ignore NS? Abdina? Definitely not, because there are few conditions where you can still give normal saline. One is going to be traumatic brain injury. Again, traumatic brain injury, the risk of cerebral edema is high. Okay. But what I said with sodium chloride, normal saline, the osmolality of normal saline is more than 300. That means it is still hypertonic to your plasma, because your plasma is going to be 275 to 295. But the fluid you are giving is going to be more than 300. Okay, normal saline osmolality is more than 300, because 154 plus 154 is 308. 308 is the osmolality of normal saline. So you are giving a little bit hypertonic fluid. So the risk of cerebral edema is little lesser when compared to other two, plasma light or your Ringer's lactate. So you can still give. And whenever you have significant hypochloremia or excess gastric loss, at that point of time you can give, because gastric loss produces what? Gastric loss produces alkalosis. You are losing a lot of acid. So if you give NS, it will produce acidosis, right? So it will be kind of equating. So you can still give NS for people who are having gastric loss. That's all. So remember these three conditions, you can give your normal saline. Right. Now coming to another topic, colloids. So colloids, what I am really concerned about it, I really ask you people to just know about albumin. Okay, albumin and whole blood, not whole blood, PRBC or whatever be it. Okay, you just know about these two, because it's gelatin, dextrin, HES. I don't even know how many of us still use it, because they come with a lot of risk factors. Okay, they come with so much risk factors. So important message which I want to actually tell through this slide is going to be this. So always for anything, use crystalloids first, and among the crystalloids, it is going to be balanced crystalloids. And if at all you want to give a colloid, always try to prefer albumin. Okay, especially in conditions like liver diseases, nephrotic syndrome, or large volume paracentesis, where we remove more than 5 liters of ascitic fluid, we can give albumin to prevent hypovolemia. HES, hydroxyethyl starch, which is like another colloid, should generally be avoided, because there is a risk of coagulopathy and acute kidney injury. Okay. So because of all this, always try to prefer crystalloids. If at all crystalloids are not effective, then you can go for colloids. In that, colloids, prefer albumin first and then all other things. Okay. So these are the types of colloids. You have albumin either as 5% or 25% solutions, sometimes 20% solutions also. And you have gelatins, which include the hemma seal, the things which we commonly, not commonly, but uncommonly used in the ICUs. And we have dextrans and hydroxyethyl starch. These are all the types of colloids which are being used. So coming to human albumin, just once again, a busy slide for human albumin, because again, it is very important. So it is a donated human plasma protein. Okay, you separate albumin from that, and it can either be given as 5% solution or 20 to 25% solution. So that's the reason why I told in the initial stage, if you give 1 liter of 20% albumin, you are going to be in jail, because it is hyper-oncotic. Okay, but what is the physiological is 5% solution. 5% means 5 grams in 100 ml of water. So that is what we have in our plasma also, right? The normal albumin level is going to be 3.5 to 5 grams per deciliter. So this is also 5 grams per deciliter. So this can be given as a iso-oncotic colloid for replacement. Okay. But if a patient is having severe hypoalbuminemia, or if you want to expand the plasma volume, then you can give 20 to 25% solution. Okay. The reason is, if you give 100 ml of this solution, this will go into the blood and it will become 4 to 5 times the volume. That is, 100 will become either 400 or 500 ml, because it will absorb water from the interstitium, because it is a very thick solution. You would have seen the albumin bottles. Okay, it will be full of froth and it will be very thick. Okay, it's like a highly viscous solution. So once it goes into the body, it absorbs water from the interstitial space and it expands the plasma. Okay. So the major functions are going to be maintains plasma osmotic pressure, expands intravascular volume. And again, we all know albumin is like a major transporter of a lot of things, bilirubins, hormones, even some of the calcium gets bound to the albumin. So all these things are like very common, which we should know. Okay. And again, they use 5% can be given for volume replacement and maintenance, whereas 25% albumin, it is like hyperoncotic, which is commonly available in our wards. It's going to be 20 or 25% albumin. So that can be given for rapid plasma volume expansion. But again, the catch here is just look at the rate with which we have to give the solution. So the rate of 5% albumin should be just 1 to 2 ml per minute, not more than that. Okay. And if it is like 25% albumin, it should be less than 1 ml per minute. That's why we give this 100 ml of 25% albumin over 4 hours. Okay. We don't give it in 1 hour or something. We give it over 4 hours. Okay. 2 hours, 3 hours, 4 hours. Like it will be a very slow infusion, because if you give it rapidly, it is going to cause problem. So don't give it rapidly. Just take a note of this rate at which you have to give. Okay. And be very careful when you are giving this for patients with nephrotic syndrome, for example. So nephrotic syndrome, what's the problem? You have, the patient has total body water, which is actually increased. Okay. Everywhere the patient will be bloated, will be like a teddy bear, fully bloated. Okay. But then the intravascular fluid is going to be less, because nephrotic syndrome, you are losing albumin. So the amount of albumin in the blood is less, because of which the blood doesn't have oncotic pressure at all. So all the fluid from the blood is going into the interstitium. Okay. So the patient is bloated. Now the amount of fluid in the blood vessel is going to be less. So you are giving albumin now. If you are giving albumin to this patient, what happens? Suddenly the oncotic pressure of the blood is going to increase. So blood will try to reabsorb all the water from the interstitial space. So if it reabsorbs more water, and if the plasma volume expands suddenly, what happens is there will be more plasma volume. Normal plasma volume is going to be 3.5 liter. Suppose think if the plasma volume becomes 5 liters. So there is 1.5 liters of excess plasma volume. That is going to cause pulmonary edema. Okay. So that is one, again, an important thing. That's why for children, if you go to Institute of Child Health and if you give albumin, we'll make sure the albumin goes very slow and we don't overdose albumin, because if you overdose albumin, the child will land up with pulmonary edema, because all the interstitial fluid will come into the blood vessel and it will increase the volume status and it will cause pulmonary edema. So any doubt with this? So this is one take home message. Albumin infusion, if it is concentrated albumin, give very slow. Any doubt with this? If at all you don't have any doubts, we'll go to the next part. Again, a thumbs up so that I can know. Okay, great. Fine. Now we'll go to the next part. Again, a busy slide. I would actually want to skip this slide, but then yeah, for the sake of completion, I'm just giving this slide. Take a screenshot, move away. That's what I'll tell. Okay. Hydroxy, if at all you get bored at any point of time, you can just go and read through that. Okay. About hydroxyethyl starch and gelatin. Okay. Just note few important things. One is from starch, hydroxyethyl starch, name itself has starch, and this gelatin polymers are from bovine collagen. So it is bovine means like cow, so bovine collagen. And volume expansion, it has a very strong volume expansion for hydroxyethyl starch. For gelatin polymer, it is kind of moderate. Okay. And cost, everything is lower than albumin, but still, why do I say prefer albumin? Means albumin is like a protein which is already in our body. But this hydroxyethyl starch and gelatin are like externally synthesized substances. So they can cause acute kidney injury, they can cause coagulopathy, they can cause anaphylaxis. So all these side effects are there. So that's the reason why we try to avoid these hydroxyethyl starch or gelatin polymers and prefer albumin for volume expansion. Or if at all the patient needs blood transfusion, you give blood transfusion. That is better. You can give fresh frozen plasma, still has albumin, so that can be given. Okay, rather than these things. So yeah, nothing more to discuss about this. For now, it doesn't deserve our time, so we'll go to the next slide. Okay. Now, before we give any fluid, okay, we should know why you are giving this fluid. So the most common indications are going to be for resuscitation, replacement, and maintenance. What is the meaning of all these? Resuscitation means your prime aim is to increase the blood volume so that all the organ gets perfused adequately. That's all. So if someone is in the shock, you give resuscitative fluids so that shock recovers and perfusion gets corrected. So that is resuscitation. Now, for example, a patient who is coming to you with GI bleed, upper GI bleed, okay, DCLD patient, upper GI bleed, like 2 liters of blood is lost, okay. So what fluid do you prefer here? Comment in the box. Which fluid do you prefer? if at all a patient who's having 2 liters of blood loss coming to you in shock, what fluid do you prefer? Let me see if someone answers that. RL, but many people say blood. Yeah, blood is the best fluid here. The patient is losing a lot of blood, so give him blood. That's all. Okay. So blood is going to be the best fluid. But yeah, if blood is not available, then you give what? You are going to give Ringer's lactate. Okay, don't give normal saline. Again, current thing is Ringer's lactate to maintain the perfusion, because obviously you can't just go and grab one bag of blood and transfuse it to the patient. Okay, you should check for cross matching. If you put the blood and if the patient goes into mismatched transfusion or any reaction, then you are doomed. That's all. Already shock, adlo reaction on the complete gone. So you have to do at least a they say in the fast cross matching will be done. Okay, rapid spin nu சொல்லுவாங்க போட்டு they'll tell you the compatibility. So you have to do that and then get the blood. But before that, you can give Ringer's lactate. But the best fluid is going to be blood. Okay. So now this resuscitation is giving the 2 liters of blood which is lost. Okay, so that is resuscitation so that the BP increases. Okay. Now after which the patient is still losing 500 ml of blood every day. I mean, not 500 ml of blood, or some 200 ml of blood is getting lost like every hour, for example. Then you have to replace it with 200 ml of fluid. Just a moment. 200 ml of fluid for every hour you should be replacing. So that is the replacement. Maintenance means there is something called insensible loss daily. Okay, right? Or the urinary loss. So the patient will be passing urine per day, and the patient will be losing a lot of water through breathing, through fecal matter, or through skin. Okay, so those are all the insensible losses. So that should be given every day. So that is the maintenance. So you have to take care of this maintenance. You have to take care of the ongoing loss, which is not a physiological loss. Insensible loss alone is physiological loss that has to happen every day. But this bleeding or something else, diarrhea, vomiting, இதெல்லாம் வந்து you have to replace. Okay, so these are all the common indications for which you have to give fluids. So before giving something, you should know why you are giving. That's a basic thing. Okay, so 4 questions before prescribing. Why am I giving fluids first? Which fluid am I going to give? How much I am going to give? What endpoint am I targeting? Okay, because everything will be a problem here. Okay, because sometimes tired varangla, give fluid, give one dextrose, give one normal saline. No, that is not the way we should practice. Okay, so you should know why you are giving fluids. As I already said, a fluid is something which goes directly into our intravascular space, bypassing all our defense mechanisms. So whatever goes in should have some accountability. Okay, why it is going in. So always think why you are going to give the fluid. Next one is which fluid. Obviously, if the patient is having diarrhea, better to give Ringer's lactate. Don't give normal saline. Okay, because normal saline increases acidosis. So which fluid and how much? How much means if the patient is passing 500 ml of loose stools or vomited out gastric contents of 500 ml, try to give 500 ml and then your ongoing loss and then the maintenance fluid also. So you should know how much to target. What is the end point? The most important question is this: what is the end point? When you should stop? Okay, when you should stop, because we'll be keeping on giving fluids. I don't even know, for most of the prescriptions, they'll be like NS at 75 ml per hour. It is like a very standard prescription, NS at 50 ml per hour. I don't even know why that is actually happening. Okay, you should know why you are giving fluids and you should know when you should stop it. Once the patient is able to take fluids through peroral route, stop IV fluids. That's all. It is like a straightforward thing. If the patient is sensible, if the patient is not able to, not going to aspirate, good deglutition reflex, then you please do give oral fluids. Stop IV fluids. That's all. Okay. Unless you have to give some IV drugs, which should be mixed in normal saline or something. Okay. So that's the only time you should give IV fluids. So all these questions has to be addressed. The next part. Yeah, next part I'll be telling about resuscitation and how to monitor this electrolyte, fluid status of the body. Just give me a moment. My laptop is going to get switched off in few seconds. Yes, my laptop has gone, resuscitation phase is over and it's in the maintenance phase now. Okay. Yeah. So coming to fluid resuscitation. So what is the usual protocol by which we give fluid resuscitation is the common protocol which is used is give a 500 ml of crystalloids, preferably balanced crystalloids like RL over 15 minutes. Okay. And you have to reassess the response. Okay. You should know how to reassess the response, which will be in the next slide. Okay. So most commonly we used to use normal saline, but now again balanced crystalloid is indicated. I'm telling this for maybe fifth or sixth time because you should remember that. Okay. I'll tell that for another 5, 6 times also. Okay. Yes. So you give 500 ml of crystalloids over 15 minutes, okay, as a bolus dose, and then you recheck the response. So the target is going to be mean arterial pressure of more than 65 millimeters of mercury. So the next question obviously is how do you calculate mean arterial pressure? So can someone tell me how to calculate mean arterial pressure? MAP. What is the formula of MAP? It's diastolic blood pressure plus 1/3 of pulse pressure. Okay, so that's what is your mean arterial pressure. So the mean arterial pressure should be maintained at more than 65 millimeters of mercury because it has been proved in a lot of trials that maintaining the mean arterial pressure at 65 millimeters of mercury maintains organ perfusion to an extent that organ injury is reduced. Okay, so the 65 is a magic number. Whenever we are given a call, nephrology call, we'll just go and look at the BP. If the BP is 80, 60, 70, 40, we'll be like, titrate pressors to maintain mean arterial pressure more than 65 millimeters of mercury. That's all. That's what we write first. We have to titrate the vasopressors to increase the blood pressure, mean arterial pressure to more than 65 because it maintains perfusion to a relatively decent extent. Okay. So that should be our target. Okay. So once you give this 500 ml, recheck the response, whether the BP is increasing or whether if, for example, most commonly what will happen is we would have come across this situation. A patient's BP will be 190 and pulse rate is going to be 110. What does it mean? BP is 100 bar 90 millimeters of mercury and heart rate is going to be 110, 120. What is this? Very commonly encountered scenario. Especially ஒரு patient dengue இருக்காங்க, dengue fever, okay, BP 190 and high pulse rate. So that is the second stage of shock, which is compensated shock. Okay, next stage is going to be uncompensated or decompensated. Okay, compensated shock la enna avuna, your pulse pressure will fall. Okay, your body will try to maintain pressure, vasoconstriction, diastolic pressure will increase, systolic pressure will be low. So 100 over 90, your pulse pressure is just going to be 10. And this tachycardia means the body is trying to pump blood to a great extent. So this is in a state of compensated shock. So what happens is sometimes if you give this 500 ml of fluid, the tachycardia will settle first. So from 120, it will come down to 90, 85. So if it comes, it means this patient is actually fluid responsive. Okay, if you recheck BP after some time, it might become 120, 100, 120, 90, something like that. Your pulse pressure will start to increase. Okay, now at this stage, you have to assess if there is any signs of volume overload. So how do you check if there is volume overload means? Commonly, we check basal crepitations. Okay, we check we auscultate the lung bases. Lung bases, if there is crepitations, that means there is volume overload. Next thing, through machine we check IVC diameter, inferior vena cava's diameter. So if inferior vena cava's diameter is more than 2.1 centimeter and it is less than 50% collapsible with respiration, so many criteria are there. So that will tell whether the patient is volume overloaded or not. If it is not there, then we go ahead with lung ultrasound. Okay, if you check lung ultrasound, there will be something called B lines. Okay, white lines which will be going through from top to bottom. There will be white lines which will be going through that. We call that as B lines. The B lines line interstitial fluid in the lungs. That's all. So if the B lines are there, then there is volume overload. So if none of these are there, then you can give more fluids to this patient so that the patient becomes better. So that's how we usually calculate we usually check for signs of volume overload. And with every bolus, you have to reassess the patient. Okay, so 500 ml over 15 minutes is the starting point from which we can go. But what is the fluid bolus recommended for a patient with septic shock? Surviving sepsis guidelines. What is the magic number which is being given for the initial bolus? Can anyone let me know? Yes, it is 30 ml per kg as the bolus. So if it is 50 kg of a person, you have to give 1500 ml as the bolus. Okay, so that's how they say it is 30 ml per kg as the bolus dose. Okay, for sepsis. Now, again, a busy slide. Again, I don't want to go into too much details. We should know very common conditions. Okay, septic shock, DKA, acute gastroenteritis, burns, hypercalcemia, cirrhosis. In all these people, we might need to give fluid. Just look at the septic shock. For any shock, be it any shock, the preferred fluid is going to be balanced crystallites. Okay, so RL or plasma light. Next, DKA. DKA, the initial problem is going to be dehydration. Okay, so for dehydration, the fluid is going to be NS. Okay, so once you give NS and correct the dehydration, then you switch over to either half normal saline or balanced fluid or ringer lactate. Even though ADA guidelines says you have to give half normal saline, they don't mention about ringer's lactate, but still the practice is give either ringer's lactate or half normal saline. Don't give normal saline continuously. Okay, you can give half normal saline. For gastroenteritis, especially vomiting, okay, what is going to be the treatment of choice? Ringer's lactate, or if this volume or if this gastroenteritis results in shock, what is going to be the treatment of choice? Again, shock irundale, it is going to be balanced fluids. Okay, but in the condition, you have to be a little bit more careful because gastroenteritis, the patient will already be having alkalosis. Okay, if you give RL, more RL, that is going to worsen your alkalosis. So at this point of time, you can still give NS to this patient. That's what I said in the previous slide. Okay, so you can write a bar in this and give NS also. So RL bar NS. Okay, depending on the scenario, you can prefer NS in this case because NS is you can consider NS as an acidic fluid. Okay, even though it is not acidic fluid, you can consider it as an acidic fluid. So in gas like vomiting, you lose acid, so you give NS. In diarrhea, you lose base, so you give RL. So that is the thing. Mela pona NS, keela pona RL. That's all. Okay. Then burns. Okay. Again, burns the most common burns. The problem again is going to be one important thing. You lose a lot of fluid through the skin. Okay, your insensible loss is going to increase a lot. So whenever there is insensible loss increasing also, you have to give RL only as the treatment of choice. Again, for everything, it is going to be RL. But again, in burns patient, you will also lose a lot of albumin. So you have to check the serum albumin level and think whether you should give albumin to this patient. Okay, and hypercalcemia. So tell me one condition, one important condition in elderly which can cause hypercalcemia. Elderly, more than 60 years old, male, back pain, pedal edema, bone lesions. So yes, someone says malignancy, multiple myeloma. Yeah, exactly. So for example, multiple myeloma. Multiple myeloma la hypercalcemia இருக்கும். Okay. Or hyperparathyroidism, you will have hypercalcemia, primary hyperparathyroidism. Vitamin D toxicity, you can have hypercalcemia. Milk alkali syndrome, hypercalcemia. So many things are there. So whenever there is hypercalcemia, the treatment of choice is going to be NS. Remember this, note it down separately. Okay, because look at the line which I have written at the bottom. Normal saline promotes calciuresis. More of a nephrology concept, not going into that too much depth, but just know that NS, if you give, it will cause calciuresis. Because of that, the first treatment of choice for any hypercalcemia is going to be correcting dehydration with normal saline. Okay, there are mechanisms behind that, but again, on the mechanism explain பண்றதுக்கு I should explain a lot of physiology first. So again, already time is almost 6:30, so I don't want to bore you people more. We'll go to the next part. Okay, cirrhosis la albumin is the treatment of choice. You all know that. Okay, volume expansion with albumin is going to be the treatment of choice. Okay, so how do you assess fluid status? One is history, எவ்வளோ loss இருக்கு. Okay, urine output எவ்வளோ இருக்கு. So you have to check vomiting or diarrhea na how much is the urine output, how much the patient is taking in. So basically, what is it? Proper input output chart இருக்கணும். That's all. So examination I told about BP, compensated shock, pulse rate, tachycardia, JVP is a sign of right heart failure, volume overload. High volume overload இருந்துச்சுன்னா கூட JVP will be elevated. So all these should be taken into account. And labs, the main thing is going to be creatinine levels, okay, and lactate levels, because shock there will be anaerobic metabolism, so lactic acidosis will be there. So whenever there is increased lactate, you can tell that there is hypoperfusion. So there is less BP எடுத்துக்கலாம். அந்த BP நால acidosis இருக்குன்னு எடுத்துக்கலாம். Next one is creatinine. Whenever the BP is low again, whenever there is fluid deficit, blood flow to the kidney reduces. Because of that, there will be pre-renal acute kidney injury. So you will have increased creatinine level also. Okay, so these are all the things which can be found out. And about electrolytes, as I said, if you lose more water, if you lose more free water, your sodium level is going to be high, right? It is going to be hypernatremia because you're losing water, blood becomes thick, sodium becomes higher. Okay, so hypernatremia means the patient is having dehydration. So you can give free water. So these are the things which can actually be evaluated to assess the fluid status of a patient. And how do you check fluid responsiveness? So I said about the fluid challenge, right? You have to give 500 ml of crystalloids or 10 to 15 minutes. And what did I ask you to check? Check the BP and pulse rate first. Okay, that is mean arterial pressure we have to check. And another measurement, if at all you are in a better place where you have a echo probe, you can check cardiac output, stroke volume. Okay, you can check the stroke volume. If you give fluid and if the stroke volume increases, then it means the patient was in a fluid deficient state. Now you are giving fluid, so the stroke volume increases. Okay, stroke volume, I think you all know the amount of blood which is pumped out by a single systolic beat of our heart. So that is stroke volume. Okay, so that is that increasing other number paakano. Okay, so someone is called as volume responders when the cardiac output increases by 10 to 15%. Okay, means there is good response. When there is no response, then they are called non-responders. Okay, either which one you have to give fluid assessment. More than this, all of you should know about this because none of us will be having none of us will know how to do an echo. Okay, so on the samayathala you should know about passive leg raising test, very easy to perform. So basically the concept here is make the patient lie down and then lift the patient's leg. Okay, so ஏன் leg lift பண்றோம்? So much blood is pooled in the capacitance vessels. What are capacitance vessels? Resistant vessels of the body யாரு? Capacitance vessels of the body யாரு? Resistance vessels வந்து arterioles. Okay, capacitance vessels வந்து veins, venules. Okay, so they are all the capacitance vessels. So much of blood is going to be pooled in the lower limbs, in the veins. If you lift the legs up, all this will be just flowing down to the heart. Okay, so all this, like say for example 500 ml of excess blood is going to come down to the heart. Okay, and once it comes to the heart, obviously என்ன ஆகும்? Stroke volume increase ஆகும். So basically even without giving a fluid bolus you can do this. Okay, because blood from the leg is going to come down and that is going to increase the stroke volume. Stroke volume பார்க்க முடியலன்னா what is this? Pulse oximeter probe வச்சிருப்போம்ல, that probe ல வந்து you will be having waveforms. That waveform ஓட amplitude will increase. That means your blood flow is increasing, perfusion is increasing. So அதை வச்சு கூட easier we can calculate. So this is called passive leg raising test. So if it is positive, it means that the patient is in a fluid deficient state. So you have to give fluids to this patient. So that's the take home message for this. Okay. Yeah. Now coming to few cases and then we will wind up. Okay. So first one, case 1, septic shock, BP 80/50, tachycardia, lactate is 4.2. What is the drug of choice? I want you to comment. Once you comment, we'll finish off the class and go. What is the treatment of choice? Oral. Someone says oral. So not someone, only one says oral. Yes, most of you say it is oral. That's obviously the correct answer. It is going to be balanced crystalloid. Okay, either ringer lactate or plasmalite. So septic shock means there is severe intravascular volume depletion. So you give rapid volume expansion with balanced crystalloids. That is going to improve your cardiac output. That's all, very simple. Okay, so that is going to be the treatment of choice. Okay. And remember in this previous slide, why not normal saline? Again is very important. Okay, high chloride load, metabolic acidosis, possible acute kidney injury. So these days, normal saline is not indicated. It is going to be your balanced crystalloids. Next question. Diabetic ketoacidosis, BP 110/70, hyperglycemia, ketones positive. What is the treatment of choice? Yes, most of you say it is NS, exactly. So normal saline is going to be the first fluid of choice, especially if the patient is dehydrated. Okay, you have to check the BP, okay, and everything, and then do, because this normal saline is the initial fluid of choice for dehydration. These patients will be having osmotic diuresis because of high sugar. Okay, they would have lost a lot of water, and along with water, sodium also would have been lost. So you have to replace sodium and water. So NS we are giving. Okay, so the fluid therapy is going to be start with normal saline, 15 to 20 ml per kg in the first hour. Then you have to assess if the sodium levels and if the dehydration is corrected. Again, formula and so many things are there. So you have to correct sodium levels. And once sodium level reaches normal, then you have to give half normal saline or Ringer's lactate. Okay, so that's all. That is how you should proceed. Okay, the rest of this entire slide is just a common management of diabetic ketoacidosis. If you want, you can take a screenshot, because I have included when to give bicarbonate, when to give potassium, when to add dextrose. So this is like a complete slide which tells about how to manage diabetic ketoacidosis. Okay, but what is important for us for this class is going to be fluid therapy approach. That's all. Okay. Now the third case, CKD with pulmonary edema, BP 150/90, elevated JVP, creatinine 4. What fluid is indicated? What fluid is indicated? Nil. Nil. No fluid. No, exactly. One says with 2 no, exactly. Yeah, because if you give fluid, next day we have to go and count the 14 bars again and again and again and again. Okay. So if you give CKD patient with fluid, we'll be in jail. But I'll tell you one thing. I have seen that happen right in front of my eyes. Giving fluid to a CKD patient without knowing that the patient was CKD, and the patient landing up with pulmonary edema. And it was me who intubated that patient and found out that I had so much water coming out of the endotracheal tube because of pulmonary edema. Okay, this has happened during my PG time. Okay, without knowing that the patient is CKD. Okay, the BP was low, something like that. They give like too much resuscitative fluids, and patient landed up with pulmonary edema. Okay, so you should ask a lot of history. So this is like a very complicated state. Whenever the patient is CKD, okay, be very careful in giving fluid. Other than CKD patient is in shock. I will not give fluid. That is not the right way. You should give fluid carefully. Okay. Fine. So no routine IV fluids for this problem. So the problem is too much fluid, not too little fluid. So don't give fluid at all. Okay. Then this one, 45-year-old man, persistent vomiting for 3 days, BP 90/60, dry mucous membrane. What IV fluid would you prefer? NSA RLA? Again, controversial answer. Half say NS, half say RL. You guess what I would have told? Shocking, no? I would have told normal saline, because the reason is what I am considered about here is this patient is losing a lot of acid. So this patient will be in a state of alkalosis. So I don't want to give alkalosis like patient. I don't want to give RL. So that's the reason why I have given as normal saline. But again, just look at this. I have given the reason also. Ringer's lactate contains lactate, so may worsen alkalosis. But again, you can argue with me. So if someone argues with me, I'll be very happy, because the BP is 90/60, which means the patient is in hypotension. So whenever there is hypotension, RL can be given, right? Yeah, it can be given. Not a problem. But NS can also be given, right? NS can also be given. Why NS was not supposed to be given? Because it caused acidosis. But here, acidosis is not the problem. Here, alkalosis is the problem. So you can still give normal saline. Okay, so that's how we work, right? Among the controversies, navigating through difficult waters. That's what we should do. Okay, so normal saline is going to be the answer here. Next one. 30-year-old, watery diarrhea, vomiting, weakness, thirst, dry mouth. BP is 100, 110, 70. Okay. This patient comes to you. Read the question very carefully. Which fluid would you choose for this patient? I am sure that none of you, not even one person, will get this right. If someone says, I'll give like 5,000 rupees instant GPay. Ajijo, someone has told the answer. The answer is ORS, pa. It is not going to be IV fluid. Okay. The answer is ORS. So basics comes first always. Okay. Someone who is coming with diarrhea for a long time, Okay, and not a long time, 2 days, with a good BP, 120. That's what I said, is BP is 120. Why do you want to put an IV line for and do an thing here? So the answer is going to be ORS, oral rehydration salt. Basics is always basic. Okay, give ORS first. ORS எப்படி கொடுப்பீங்க? How much the loss is. So you have to match the loss with oral rehydration salt. Okay. So only when the patient comes in shock, then you have to give IV fluid. Okay. So what is the IV fluid of choice here? It is going to be Ringer's lactate because this patient is losing a lot of bicarbonate. Okay. So you have to give bicarbonate. So RL can be given for this patient. Okay. And RL, the problem is it has potassium. Okay, but then the potassium level is going to be just 4. So if this patient has more loss of potassium, then you have to add potassium chloride separately. Okay, and give it. Okay, so ORS எப்பவுமே மறந்துடாதீங்க, and never ever prescribe ORS tetra packs to anyone because they are not ORS. You know the controversy which is happening. One lady is fighting her life out for that. Okay, so don't ever prescribe tetra pack ORS. Always give that packet ORS, which should be mixed in 1 liter of boiled and ஆற வச்ச water, and drink it over 24 hours. Use it within 24 hours. Okay, so that should always be remembered. Next one, post-operative patient. Again, one pretty interesting slide. So underwent uncomplicated inguinal hernia surgery, hemodynamically stable, urine output adequate, no problem at all. One normal patient, inguinal hernia surgery, kept a nil per oral for 24 hours. What will you give for 24 hours? Now tell me. Because this is like one important line you should remember. Okay, because there is something called maintenance fluid for a patient. So whoever comes with us, we should know what the maintenance fluid is. So most of you say it is dextrose D5. D5 la enna irukku? You have sugar and you have water, but does it have electrolytes? We don't need electrolytes. Water and sugar mattum kodutha poduma? No la. So what is needed actually? Isolate RL. Okay, I'll tell you how we go about this. Okay, for this we should know about what is this first. Okay, just look at this. Normal amount of water needed per day is going to be 200 ml, 2000 ml, which is 2 liters. Okay, and the normal electrolyte need is going to be 1 milliequivalent per kg of sodium, 1 milliequivalent per kg of potassium, and dextrose around 50 to 100 grams per day to prevent starvation ketosis. Okay, there's something called starvation ketosis. Okay, so to prevent that, we should need 50 to 100 grams of dextrose per day. Okay, on top of that, the insensible fluid loss. Okay, insensible fluid loss is going to be 1 liter. Skin valiya 500 ml is lost, through lung it is 400 ml, and through stool it is 100 ml. So 1000 ml of insensible fluid loss. And most of us will not know about this insensible fluid input, which means water is generated inside our body through metabolism. Okay, through oxidative reactions, water is generated inside our body, and that is going to be 300 ml of water. So 300 ml of water is generated, 1000 ml of water is lost. So the total insensible loss per day is going to be 700 ml. So obviously, the 700 ml has to be replaced on top of what? Sensible fluid loss. Sensible fluid loss na enna? The fluid loss which we are able to sense, that is urine output. Okay, so urine output plus 700 ml should be the daily fluid requirement for a patient. Okay, so urine output, which is the sensible loss, and 700 ml, which is the insensible loss. Okay, so how can we give this? Is like this. Okay, so the routine maintenance water required is 30 ml per kg per day, around that. Okay, sodium, I said it is 1 milliequivalent, potassium 1 milliequivalent, and dextrose it is 50 to 100 grams per day. So remember this one. This is the actual fluid prescription which you give. It is half normal saline with 5% dextrose with addition of 20 milliequivalents per liter of KCl. It meaning enna, you would have known DNS, right? DNS படிச்சிருப்போம், dextrose normal saline, right? DNS. Okay, so this is something called half DNS. There will be something called half DNS, which means 5% dextrose mixed with half normal saline. Okay, so that is half DNS. So you have to take half DNS, and for every 1 liter of half DNS, you have to add 20 milliequivalents of potassium chloride. Okay, this can be given for 2 liters. Illa in the 30 ml per kg per day, evlo water varudho avlo. That is the usual maintenance fluid. For example, if the patient is 70 kg, so 70 multiplied by 30 is 2100. So 2100 ml of this entire fluid should be given. That is 2100 ml of half DNS with 20 milliequivalents per liter of KCl. That's all. So 20 milliequivalents per liter na inge 2 liters varada. So 40 milliequivalents of potassium will usually be given. So that is the routine maintenance fluid which we usually give. So if we calculate now, just think half saline half normal saline 154 sodium irukadu adukla பாதி தான் இருக்கும். So it is going to be 77 and 77 of sodium and chloride. So for 2 liters you are giving 154 milliequivalents and 154 milliequivalents of sodium chloride in total. So 1 literல 50 grams dextrose இருக்கும், 2 litersல 100 grams dextrose இருக்கும், and you are giving 40 milliequivalents of potassium. So typical daily need is 2000 to 2500 ml of water. So in the fluid கொடுத்தா you provide 2 liters of water. Sodium around 70 to 100 millimole is needed. You give a little excess, 154 கொடுக்கிறோம். Potassium is 40 to 80. You almost give the required range, which is 40. Glucose is 50 to 100 grams to prevent starvation acidosis. You give 100 grams through this prescription. So if at all someone asks you what is the maintenance fluid for an uncomplicated patient who is on nil per oral, it is half dextrose normal saline, half DNS. Okay, 2 liters. அதில் 40 milliequivalents of potassium totally கொடுத்துருக்கணும். Okay, so this is how we give maintenance fluid. Now coming to the last 2 slides of the thing. One is drip rate. இது நல்லா ஞாபகம் வச்சுக்கோங்க. Okay, most of you might need this. Okay, so how to calculate in the drip? நம்ம நார்மல் ஒரு big IV fluid set இருக்கும், and pediatricsல அந்த micro drip set இருக்கும், வேகமா விழும். Okay, that is micro drip set. So if it is a normal IV set, okay, you just have to divide the ml per hour divided by 4. For example, if you want to give 100 ml per hour of fluid, okay, to a particular patient, divided by 4. So 100 divided by 4 is 25. So you give 25 drops per minute. So if you set it as 25 drops per minute, it is 100 ml per hour. If you want to give 500 ml per hour, so 500 divided by 4 is 125. So give 125 drops per minute. You set it like that. That's all. So if you set it like that, it is going to go normal. There is something called drop factor. Drop factor is 15 GTT per ml. GTT na gatta. Gatta is a Latin term. Gatta means drop. That's all. Drops per minute, drops per ml ne vechikalam. So in the பெரிய drip setல 1 ml fluid கொண்டு வரணும் அப்படின்னா 15 drops தேவை. So 15 drops விழுந்தா it is 1 ml. அதுதான் calculation. Nothing big is here. Okay, so 15 drops will make 1 ml in the normal IV set, whereas in the micro drip set, it is going to be 60 drops per ml. Okay, it is going to be 60 drops per ml. So adukku vandu romba easy. Actually, it is not at all difficult. Okay, just look at this. The ml per hour is equivalent to the drops per minute. Avladha. Okay, so normal drip set it is divided by 4. In the micro drip set, it is the same. 60 drops per minute means 60 ml per hour. 500 drops per minute means it is 500 ml per hour. That's all. So very simple. So this we should remember. Very easy to do it bedside. So the common mistakes which we do, again, I will tell this 10 times. So giving NS to everyone is like a very common mistake. Not reassessing after every bolus. That is one thing. Ignoring chloride load. Again, NS la problem chloride da. It is not the sodium which is the problem. Chloride is the problem. So we ignore chloride. So to a great extent that it will cause metabolic acidosis. So ignoring chloride is one very important thing. Then continuing maintenance fluids indefinitely. No one will tell you stop IV fluids. For the safety, admission இருக்க வரைக்கும் IV fluids போட்டுட்டே இருப்போம் அப்படின்னு சொல்லுவோம். That is not at all indicated. Okay. Again, a simple thrombophlebitis through the venflon can make the patient go into septic shock. Okay. I have seen a patient who has gone for amputation, okay, at the wrist for this particular IV set. Putting IV, extravasation, necrosis, sepsis, shock. So take away the hand. Total hand is gone. So that is the importance of every single prick which we make into the patient. Next one, treating BP instead of perfusion. Again, that is very important. Perfusion is what we target here. BP is not what we target here. We should know whether each organ is perfused to a good extent. When every organ is perfused to a good extent, they will function normally. If they are not perfused, they will not function normally. So BP in illama, we have to check whether the organs are functioning normally through the various testing methods which are available. Next one is missing fluid overload. Give fluid to a great extent till the patient develops pulmonary edema. That again is not going to do very good. In fact, there are a lot of papers which say over treating with IV fluids, over hydration results in kidney injury. Okay, in nephrology they say. Okay, you try to treat kidney injury by giving fluid, but then if you overhydrate the patient, there will be again kidney injury which is happening. That is due to increased venous pressure. So much fluid in the venous space that there is increased back pressure. Renal vein pressure அதிகமாயிடும். அதிகமாயிட்டு perfusion ஒழுங்கா இருக்காது. Artery வழியா blood வராது. ஏன்னா vein pressure அதிகமா இருக்கு because of volume overload. So all these things will happen. And last one, assuming hypotension always needs more fluid. It is not so. ஓகே, ஹைப்போடென்ஷன் இருந்தால் கண்டிப்பாக இன்னும் மோர் ஃப்ளூயிட்னு கொடுத்துட்டே இருக்கக்கூடாது. பிகாஸ் சம்டைம்ஸ் திஸ் ஃப்ளூயிட் வில் கோ இன் டு த இன்டர்ஸ்டிஷியல் ஸ்பேஸ், இன்ட்ராசெல்லுலர் ஸ்பேஸ் அண்ட் மேக் ப்ராப்ளம் இன் தோஸ் ஸ்பேசஸ். Okay, so don't think that hypotension always needs more fluid. Sometimes it needs albumin, sometimes it needs vasopressors, so you have to give that. Okay, don't just go ahead with fluids. So final take home message is going to be fluids are drugs. Fluids are not some random fluids. They are all drugs. Whatever goes inside the vein is a drug always. So fluids are drugs. Every prescription before giving it, you should know why you are giving it. Okay, whether for resuscitation, replacement, or maintenance, or as a vehicle for giving a drug, you should know that. Crystalloids are the foundation. Again, I say colloids we didn't discuss a lot. Only crystalloids are very, as I said, albumin only for selected indication. Synthetic colloids very limited roles. So first line in most clinical situation is going to be crystalloids. So நாங்க நெஃப்ரோல ஒன்னு சொல்லுவோம், when in doubt dialyze the patient. When you are asked for any opinion, if you don't know whether we should either dialyze the patient or not, the rule of thumb is dialyze the patient. So when in doubt, dialyze. So I have put the same line. When in doubt, choose a crystalloid. Don't use a colloid. Okay, so always crystalloids. Overload is more dangerous than underfilling. Again, that is one important take-home message. Okay, so the commonest mistake is continuing fluids after they are not needed at all. So you have to assess response after every fluid bolus. Look for fluid responsiveness, and only when there is fluid responsiveness, you have to give more fluid. Okay, and you have to stop when the goal is achieved. Obviously, every liter should have a purpose. Every minute of time spent should have a purpose. Okay, so that's all for today. I'm really sorry for continuing class for like a long time, but then it is like very important topic which is to be needed.
Anyone have any doubts? Sir, can we have doubt clearing session or something?
Yes, sure. We can have 2-3 minutes for that. How to manage septic shock in CKD? Okay, so septic shock, the treatment of choice is going to be fluids. Be it a CKD patient, you have to give fluids. Okay, because septic shock is a kind of distributive shock. You have vasodilation. Okay, so you have to fill the intravascular volume somehow. Because if you let the patient be in septic shock, the patient will die. Okay, so you have to give fluids. Okay, but then it has to be very guarded. So I said about this fluid responsiveness and checking for this B lines and IVC diameter. We will be doing that very carefully in CKD patients. Okay, instead of 500 ml, sometimes we give 200 ml of bolus, 250 ml of bolus. So it depends. Sir, you mentioned plasmalate as a non-pyrogenic. Can fluids be pyrogenic? Any fluid can be pyrogenic if administered inappropriately. Okay, so this non-pyrogenic is not just for plasmalate. It will be labeled in almost all the fluids. Okay, it is non-pyrogenic because obviously we don't give pyrogenic fluid to anyone. Okay. So any more doubts?
Anyone have any doubts?
Use of 0.45% saline. So 0.45% saline is a hypotonic fluid. Okay. So when do we give hypotonic fluid? So hypotonic fluid you give only when there is hypotonic fluid. நீங்க எப்படி ஞாபகம் uh, 5% dextrose, right? So at that time you can give 0.45% saline because it also adds more water. But again, best situation will be ask the patient to drink water or put Ryle's tube and put free water into the stomach directly. That is the best thing. But since you asked, I'm telling it. Is indication for D5 water and 0.45% saline the same? Yeah, it is almost the same. But again, there are very subtle differences. Okay. Sometimes you need to reduce your sodium levels from 160 to 150 in a slower rate. Okay, if you have to reduce it in a slower rate, you can use 0.45% saline because it also has sodium, right? So, another sodium fast குறையாது, slow குறையும். If you give 5% dextrose, the sodium will fall very fast. Okay, if the sodium falls very fast, 160 learn, if it comes to 120 or something, it will cause cerebral edema. You can't reduce the sodium levels very fast also. So again, lot of intricacies are there. But then if I discuss it too much, it is going to again confuse this thing. Just remember, most of the indications for D5 water and 0.45% saline are the same. Okay. Any mention on mannitol? See, mannitol, okay, mannitol intravascular volume la dhaan irukum. It is going to be acting as an osmotic agent. It's a hypertonic solution. So எதுக்கு usually கொடுப்பாங்க mannitol அப்படின்னா either to increase BP in some instances because it expands the plasma volume or to take away water from the brain during cerebral edema. If a patient has stroke, okay, illa if the patient has some cerebral edema due to something, okay, if you give mannitol, this mannitol is going to absorb water from the brain and it will reduce the cerebral edema. So that is the most common use for mannitol. But this mannitol will cause hyperosmotic injury to the kidney. Okay, so there is something called mannitol acute kidney injury, mannitol induced acute kidney injury. Okay, so in a patient who is having acute kidney injury, you shouldn't give mannitol because mannitol will worsen the acute kidney injury. So mannitol is basically a hypertonic solution. Hypertonic solution எதுக்கு கொடுப்பீங்க? எடிமாவை குறைக்கிறதுக்கு கொடுப்பீங்க because it absorbs water from all the cells. That's all. That is the take home message. How to manage septic shock in CKD? Ideal fluid, we do give NS only because septic shock in CKD patients, we give NS only because RL potassium is there. Okay, RL has potassium. CKD patients already has high potassium levels, hyperkalemia இருக்கும். Okay, so அவங்களுக்கு we don't usually give RL because RL already has potassium. So we give NS for CKD patients. One class on ionotropes and titration of it in ICU settings and practice. That's the domain of an anesthesiologist or an intensivist. But yeah, if you want to discuss, I can still do that. Okay. What are the ionotropes which are upcoming? We know noradrenaline, dopamine. Dopamine is outdated, nothing. Okay. Now norad only is given. And the second line is going to be your vasopressin. And what is the third inotrope which is on the pipeline, which is going to come in some time? Any idea? It is going to be angiotensin. Someone is close. Someone said renin. It is not renin. It is going to be angiotensin. Okay, it is going to come soon as one of the inotropes. Okay, angiotensin will be coming up soon. So if a patient has a central line, can we use CVP to assess fluid response and fluid deficit? Definitely. Okay, it is still an invasive procedure. You have to put a Swan-Ganz catheter and go and put it in the central vein and then see how it is going to be, how the central venous pressure is going to be. That is not possible in all the setups other than ICUs. Okay, so non-invasive எப்படி பார்க்கலாம்? IVC diameter, lungல B lines இருக்கான்னு பார்க்கலாம். So that is how we usually do stroke volume assessment. அதெல்லாம் பண்ணலாம். If you have a central line, very good. You can just go and directly measure the CVP. Okay. Sir, I want to give 10 ml of multivitamin infusion to the normal patient. Best fluid is RL 500 ml. What I'll prefer is always use normal saline or 5% dextrose as a vehicle for your drugs. Because sometimes RL, if you put some drug into it, it will start precipitating. Okay, so RL is usually not preferred. You prefer either normal saline or you prefer 5% dextrose. What do you think about normal drinking water having lots of electrolytes in bottles from the shops? Or is it good or bad? The amount of electrolytes in a packed drinking water is almost negligible. Okay, it is like very less. Unless you drink 100 liters of water per day, it is not going to cause any problem. Obviously, we won't drink 100 liters of water. If we drink 100 liters of water per day, we will end up with water toxicity more than the electrolyte toxicity from the water. Okay, so it is going to be the problem with the water. volume அதிகமாகணும். That is when we call volume overload. So intravascular volume அதிகமாகணும்னா free water விட sodium containing water will be the villains. If you give 3% saline to a great extent, it is going to increase the extracellular fluid and that is going to cause volume overload. Okay, so free water விட all other things are going to be bad. Because free water will cause volume overload within the cells. It will go more into the intracellular space. Intracellular space than a 2/3. So 2/3 of the free water is going into the intracellular space. So it will cause cell swelling. So that is going to be the problem with free water. Fine. I think all the questions are answered with.
Yes, sir.
Okay.
Thank you so much, sir.
Yeah. Thanks for being actively involved, man. A lot of people are actually answering. That's good.
Thank you so much.
Okay. So thanks a lot. So how I have tried to pace the next few classes is next class is going to be on next Sunday, which is only on sodium. Okay. That is not going to be an extensive class like that because it is more like a max class. Okay. Sodium is going to be a math class. It is like, it can be done very fast. Okay. Like I have some short way of teaching sodium. So we'll do it that way. Okay. So we'll do it sodium on one day and then we'll do it potassium probably on one day. And then we'll do with all other electrolytes on one day. So it's going to be a 4-class session and we'll wind it off with that.
Yes, sir.
Okay.
Thank you so much, sir.
Thank you. Take care.